Diving into locally advanced disease, where tumor is larger here and there is, in fact, nodal involvement. Here, TCHP has been the standard of care in neoadjuvant settings. Yes, we've seen PAT-CR rate, which are better, but of course, it comes with increased toxicity. Sarah, your treatment paradigm here?
Yeah, so I think in the US, we've definitely moved towards a locally advanced or stage two or stage three, which is the cutoff of 2 centimeters or greater and node positives. You want to give them neoadjuvant treatment because the reason for neoadjuvant treatment is to assess the response and to escalate or de escalate therapy based on that, which, the opportunity for adjuvant TDM1 is probably one of the most notable interventions we've done in the last decade, reducing the risk of distant disease and improving overall survival. So that's something that you really don't want to miss in these patients. Now, we have studies that have looked at anthracycline, taxane, HP versus TCHP. And while TCHP was very slightly inferior, it was almost the same. And it certainly had less long term bad side effects than the anthracycline, cytoxan, taxane HP regimen, which had a higher risk of heart failure and a higher risk of leukemia. And so, for the vast majority of patients, I am going to use TCHP. I have used ACTHP in some patients. I can think of two cases this year where the patient had a HER2 positive primary tumor, but their lymph node was HER2 negative.
Huh.
Or there were two tumors, one was HER2 positive and one was HER2 negative. And you wanted to sort of give a regimen that was going to effectively treat the heterogeneity of a hormone receptor positive, HER2 positive, and HER2 negative tumor. That is when I have actually in the past used the ACTHP regimen. But for the vast majority of patients, I think we're going to go forward with TCHP.
At SWCS, they actually did a survey saying how many people are using anthracyclines in HER2 positive disease, no other caveat. And about 30-40% of the crowd raised their hands. This is what's available outside the US. In my practice, I have not used anthracycline much in this patient population. We have anti-HER2 therapy, dual anti-HER2 therapy. We have to keep side effects in mind. Even with TCHP, we have to keep diarrhea with pertuzumab in mind, neuropathy that comes along with Taxol, marrow suppression with carboplatin, of course, the cardiotoxicity with any anti-HER2 agents. Sarah, any clinical pearls around managing toxicities with this regimen?
Yeah, I mean, I think the TCHP regimen is really tough. And I warn my patients about that. I think it's pretty challenging regimen to get through. I think it's important to tell them at the first sign of diarrhea to start taking Imodium because there's a lot of diarrhea with this regimen. Just counseling them that if they're still, despite Imodium, having diarrhea, give us a call. We'll prescribe Lamodal. If you're not keeping up with your fluid intake, give us a call, come in for some IV fluids. It's not an easy regimen. About a third of my patients on TCHP, I end up de-escalating to just THP. I haven't looked at that statistically, but I can just think of this year alone, 3 or 4 patients who I tried dose reducing once, I tried dose reducing again. They were still miserable. And then I ended up flipping them to weekly Taxol HP. And I would say I have to do that a quarter to a third of the time in my practice. And so I will do that if it's necessary. I think dose reductions can be incredibly helpful. I think just really counseling them on managing the diarrhea, managing the dehydration, bringing them into the clinic early to check electrolytes, give fluids if needed, dose reducing, and then sort of last case scenario, if you can't get them through it despite a dose reduction or two, flipping them over to THP, I have done.
Okay, so after neoadjuvant treatment, if we have residual disease, we touched on this briefly, we can consider escalating to TDM1. And this happens in about 30 to 40% of our patients. We now have mature data for Catherine trial, which is amazing because of the overall survival benefit. Sarah, every now and then, this residual disease is indeed microscopic. Are you still reaching out for TDM1 in that scenario, or do you feel comfortable with ongoing dual anti-HER2 therapy?
If you look at the Catherine data, it didn't matter what amount of residual disease the patient had. there was a benefit to doing TDM1. And so really for any residual disease at all, I am offering TDM1. Now, of course, if there's poor tolerance to TDM1 or they're developing worsening neuropathy because of the TDM1, I think for someone with RCB1 disease, you would be more likely to stop early and then finish with the Herceptin with or without Perjeta. For any degree of residual disease, I am offering it. I also think it's really important, it's not mentioned here, but I think we're learning more and more that in hormone receptor positive, HER2 positive patients, optimizing endocrine therapy is very important as well. So in the residual disease and the PCR patients that are hormone receptor positive, I am still strongly recommending endocrine therapy.
Right. We're going to bug you with PATINA trial when we talk about the metastatic population. But yes, that is my approach as well. And I'm sure, Robert, that's your approach as well with endocrine therapy in adjuvant setting. And the other hesitation always is when to reinitiate HP or TDM1 at the time of radiation, after radiation here.
Yeah, it's a good question. I think I tend to initiate it when they come back. And through radiation, we have very good safety data to give radiation through trastuzumab, pertuzumab. And actually in Catherine, radiation was allowed while patients were on TDM1 as well. So I find that my patients just want to get through the rest of this and keep moving forward. And so I tend to continue it through radiation.
Okay, I know we've talked some about this triple positive patient population. Sarah, is this where you lean towards neratinib? Are you using neratinib? Who gets neratinib in your clinic, if at all?
I really have not used neratinib in the early stage setting very much. We don't have data in patients that have had pertuzumab and TDM1 and how that would impact treatment. The highest risk patients that are estrogen receptor positive and HER2 positive, had residual N2, maybe N3 disease, and you're just very worried about the risk of relapse. I think it's reasonable after a year of HP or TDM1, but we just don't have the right data for its use nowadays, and its side effects are not easy.
Absolutely. As Dr. Graf would say, I consider this for someone who's stage 3.95, as close as it gets to stage 4, and maybe bring this up.